Okay. You're live, Chris.
Hi, good evening. Thank you for joining the Old Age Faculty webinar or a faculty update. And today we've got three fantastic speakers, and we've got our chair, Amanda, starting the webinar, and we also have Josie, our vice chair-elect, to look at the questions. The theme of the webinar is going to be the Community Mental Health Transformation Program. You couldn't get any better speaker than Viral Kantaria, who's the Senior Program Manager for the CMHT Transformation Program. And it's a warm welcome to Viral. And then there are several early adopter sites, and we have a team from that Sheffield Health and Social Care Foundation Trust, Fiona Goudie, who's the Clinical Director for the Strategic Partnership, and also James Sutherland, who's the Program Manager for the Sheffield early implementation site. So it's going to be an exciting afternoon to hear from Viral on the project, and also to raise your questions. There is a question box where you may be able to put the questions in, and also we'll try to collate the questions, and Josie will be coming towards the end to collate the questions. So without further ado, I would like to welcome Amanda, our faculty chair, to start the program.
Thanks for the introduction, Chris. I'm acutely aware time is short, and I want to allow time for you to hear from our colleagues. So here's a very brief background. First slide, please. Okay. Whilst we're discussing the Community Mental Health Transformation Programme, it obviously is happening at a very unique time with COVID being around. I don't think anything on this slide will surprise you. PHE has already told us about the disparities in risks and outcomes, and NHSE has produced a report about the aftercare needs of patients recovering from COVID. So going forward, the focus will be on a community-based asset model, and that's really using the strengths within the community as part of your basis going forward. It's about integration, and obviously that's not just about buildings. It's about acknowledging that we're talking about mental health well-being, and quite a lot of that, in fact most of it, isn't actually what is in the control of the NHS. But it's also about addressing the most disadvantaged people and making sure that whatever measures of success we decide on are ones that fit the whole of the community and mean something to them. So it's a very different way of working, with us being part of a system supporting community leaders. Next slide, please. For those of you who think that you're getting a cerebral sense of deja vu, you're correct. You have seen this slide before. It summarizes the process which I went through last time. Next slide, please. So what? I think that, as you're aware, this work becomes even more crucial at the time of COVID. And you know, if we don't articulate what the how important it is that the needs of older people are considered, then all the other people's needs, which are all very important, will take priority. So it is our opportunity to be at the forefront of ensuring that change is put in place that ensures that older people get their needs met. So next slide, please. So this is a link that previously I've sent round to you with the links for the summary from NHS England, and then the advice from the King's Fund about what needs to be in place when you're thinking about the transformation of care. And Kitty, hence the Superwoman bit, has sent round the summary to you in May. We can send it again if you want. Next slide, please. What the framework wants to do is to avoid unnecessary repeat assessments and referrals and sending them backwards and forwards. It wants to stop silo working, and then to ensure, and we need to ensure that older people aren't excluded from accessing any of the services, and that people don't get sent out of the service without support. So I think these are actual aims that we would all want for any service going forward. And this is an opportunity to really make a difference. So there's my overview, and I want to now pass on to my colleagues who are going to tell you what it's really like on the ground. So I'll hand over to Fiona and James.
Thank you, Amanda, for your update. Good afternoon, everyone. My name's James Sutherland. I'm the Programme Manager of the Primary and Community Mental Health Transformation Programme here in Sheffield. I'm joined by my colleague Fiona Goudie, who is our Joint Senior Responsible Officer, Clinical Director of Strategic Partnerships and Consultant Clinical Psychologists. We're sharing a presentation, socially distancing, so we've got a oscillating camera, so I'll hand over to Fiona shortly, but I'll be kicking off this presentation. So if we could have next slide, please.
James, could you turn your camera on, please?
Oh, I do apologise, I thought it was on. Is that any better now?
No.
Oh. I'm showing in the bottom corner of the screen as camera on.
We can just do it with your slides then.
Slides.
Okay, if everyone can still hear me, it's probably not a bad thing that you can't see me. That might be a blessed relief at this time on a Tuesday afternoon. We'll proceed just as we are now, and hopefully the technical problems will resolve themselves by question and answer time. So I do apologise about that. Next slide, please. So as Amanda had mentioned within the links that were previously sent round, Sheffield's work is contained within the NHS long-term plan and the mental health implementation plan that runs from 2019-20 to 2023-24, and is fundamentally the parts that applies to both adults and older adults is the new integrated models for adults with serious mental illness, which includes care for people with eating disorders, mental health rehabilitation needs, and a personality disorder diagnosis or characteristics of personality disorder that covers both community provision and sort of secondary care and dedicated services, with the goal that this model will achieve an additional 370,000 adults and older adults per year, having greater choice and control over their care and are supported to live well in their communities. Next slide, please. Thank you. Sheffield is one of 12 national early implementer sites that are testing new ways of delivering the community mental health framework for adults and older adults. And in Sheffield, we have the additional focus on eating disorders and personality disorder. In our test phase work, we have 15 primary care networks in Sheffield. We are working with 4 primary care networks in a test phase that represents 1/3 of the city's population. We selected our networks based on a range of criteria, which included inequalities, referrals to our secondary care single point of access, the prescribing of psychotropic medications, and the number of patients on GP SMI registers. It was important for us as well that we were able to test this model and the new ways of working as widely as possible. So each one of our primary care networks we've picked as well with key attributes or characteristics. So we have one that has a significantly higher number of BAME population compared to the city's average, another with a greater proportion of older adults, one with more families or younger adults, and also we have 2 universities in Sheffield, so we also have our student population reflected in our model. Next slide, please. So, having given the background context, we felt it was really important just to try to offer some of our learning around what has worked, any sort of top tips, if you like, and things that we've done in Sheffield and what our learning has been so far on our journey. So if we could have next slide, please. I think a key message that applies to all of the work and what we've done is this message of the same vision, but sometimes different lenses. Sometimes, despite the perceived boundaries that may exist between primary and secondary care, we've often found that the vision and the common principles are the same. Sometimes it's only the lens that's different, that we sometimes need to look through someone else's lens to understand the issue, the problem, or see it from their perspective. And that's really helped us to form the commonalities and to actually have that core joint vision. Next slide, please. Thank you. In terms of what's worked well, I think some of the key headlines does need to be flexibility is absolutely key. Not needing to embark having rigid pathways or processes, but actually being able to be flexible in the need of older adults and flexible at how we work across both primary and secondary care. Within our organisations and within our communities, there are multiple cultures, there are multiple opportunities, differences, and actually we need a model that embraces them and enables us to work with those commonalities, but not being defined by rigid processes where we actually need to do things slightly differently. Additionally, it's a case of us reaching out to new and wider partners and looking through their lenses. We've worked closely with a number of community anchor organisations. We've also tried to walk in their shoes, learning what they experience every day with older adults, some of whom might be hidden from our secondary care services. So we've learned how to use the intelligence and experiences of others, and also as well to actually let another experts to define the local pathways and us relinquishing some of the control that we would want to have to actually work in a more partnership based setting. Part of that clearly is underpinned by compromise and shared values. It can be challenging, it's equally rewarding. Whilst collectively individuals on this call, their trusts, their ICS may cover a huge population. In the past, we've been developed services at a large population level, but actually when we look across our own areas that we work in every day, we know full well there are differences of inequalities of age, of similar factors. So actually it's developing more localized solutions, more detail, and how we can respond to the needs more directly of those communities which we serve. I think another key consideration is really to be bold, to be transformational. Whilst we can sometimes feel confined by rules, protocols, sometimes even bureaucracy, this stifles the innovation that can almost in essence lead us to rearranging the deck chairs, holding the principle of really what's going to be transformational and having a culture that is based around testing and learning and developing a learning culture has been key. We acknowledge that we're going to try something new. It might not work, it might need a future iteration of it, but actually it's better to try than sometimes maintain the status quo. Finally, would be actually some of these processes and some of the ways of working in partnership can sometimes feel uncomfortable, but actually being outside of your comfort zone isn't necessarily a bad thing. Releasing that control to develop the shared common approach is really where we can start to achieve the truly transformational results that are required, and what's also part of the real excitement of this programme of work. I'll hand over to my colleague Fiona Goudie to introduce herself and continue with the rest of the presentation.
Thank you, everybody. I don't know if you can see me at all now, but if not, no worries. Could I have the next slide, please? So I just wanted to say a bit about my personal experience of being involved in the programme right from us bidding to be a pilot site. I've been a consultant clinical psychologist working in older adult community mental health teams for over 30 years. And for me, one of the things that has really worked with this programme is having older adults champions at all levels. As colleagues in the faculty will know, commissioners and providers don't necessarily align around older adults and working age mental health. In some parts of the country, old age commissioning is maybe more aligned with dementia commissioning, and not necessarily with working age adult commissioning. So having somebody involved in both the bidding and in operationalising the service who knows about older people's services, I think has been really key. Primary care, on the other hand, is a different kettle of fish from a commissioning point of view. It's whole age range from start to finish. And one of the really helpful things for us as an early implementer site has been able to use the framework, both with primary care colleagues and adults of working age colleagues, to say this is a framework for adults and older adults, and we need to make sure that the needs that come with age are part and parcel of the bid and of the testing out and implementation of the new framework going forward. It's been really helpful to have support of public health, population health data, to help us understand which of the primary care networks that we're focusing on. We're focusing on 4, as James has said, what the particular older adult population needs are in those primary care networks. Again, traditionally in secondary care, both adults and older adults, we've been used to being delivering an offer that's perhaps a bit more whole place rather than primary care network based, and it's been really useful for us to have this population health data to shape what we're doing at primary care network level. James has talked about our voluntary sector offer. We've got a considerable chunk of our programme here in Sheffield. It's about almost 20% of the whole programme budget is to support voluntary sector programmes, and we're making sure, again, by having older adults' expertise in shaping the specification and in the selection of those partners, that we've got the needs that come with age woven right through our delivery model. Next slide, please. Talked about voluntary sector contracts, so I've covered that point. So finally on this slide, we've ensured that our recruitment processes have recruited key staff with expertise across the lifespan. So just to take an example, our lead psychologist, we actually advertised the job as a 50-50 split, that we said that the post would either be undertaken by somebody with older adult expertise on a 0.5 basis and adult mental health on a 0.5 basis, or we would offer the post to somebody with expertise across the whole age range, which in fact we successfully did, and that might be something for other sites to give some thought to. We made sure that we, in terms of our values-based recruitment, we included questions linked to the whole age range, so both young adults, but for this audience, it's important for you to know that we had older adult experts on our interview panels, and that we want to test out new roles in relation to delivering services for people with presentations that might be consistent with personality disorder, employment support and pharmacy, to test their applicability across the whole age range. I think this is a challenge for some of the training models for professions such as psychology and also for psychiatry, where the competencies haven't traditionally mapped onto older adults. But I think the new competency framework, which maybe Viral will touch on shortly, will help us. Next slide, please. yeah, I think I've touched on the community framework, and I think, yeah, so yeah, finally, our community framework, which is this is our voluntary sector contract. So I've already alluded to some of the services that we are looking to contract for, making sure that those voluntary sector providers are able to deliver and support people in later life, not just working age adults. And I think there's an opportunity here for our clinical staff and service users to consider and test the evidence base around, for example, psychological interventions. We're a pilot site focusing on personality disorders and eating disorders. We know, for example, that technical example, does structured clinical management, which is a multidisciplinary team approach to supporting people with personality disorders, does that work as effectively in later life as earlier life? Is suicide risk assessment that is sort of geared up to support to risk assessment in working age adults sufficiently nuanced for those with comorbidities in later life, and can we test that out in this gap between primary and secondary care? So there's some real opportunities here for experts in later life to come to the fore and be involved in some of the research here. And I think finally, I think we're probably running out of time here. We just had a slide on things to avoid. So if we could have the next slide, please. Things to avoid. We've touched on this earlier. We are a pilot site, and we realise that we're not going to be able to get every question or eventuality or question answered in advance. COVID has given us a massive opportunity to try some things new. I'm sure that's the same across the board. But we've been experimenting with online recruitment and online induction for our programme. The long-term plan and mental health implementation plan run until 24. So we realise that now more than ever we're going to have to tweak and think about addressing problems in bite-sized chunks. We are I think again this has been perhaps a piece of COVID learning for us, being in control and feeling responsible when the timescales and the deadlines are out of our control. There's a shared responsibility, and things are changing. And I think this is the assumption that mental health needs of older adults are entirely separate for an adult population. I think the framework really gives us an opportunity to test out and work on the needs that come with age rather than an age cutoff. And I think that's it. I think there is one last slide, which is just about some practical tips, most of which we've covered. So if you just skip this slide and take us to, I've covered all of these in, James and I've covered these practical tips in our earlier content. So if you just want to go to the very last slide, thank you. It's been really enjoyable to have the time to present to you. These are our contact details, and I will now hand over to Viral Kantaria, and we're happy to be contacted and take your questions later on. Thank you.
Thank you very much, Fiona and James. Good. I was going to say good afternoon. I suppose it's kind of afternoon/evening. I'm Viral Kantaria. I'm from the National Adult Mental Health Team at NHS England and NHS Improvement, and I also sort of hold some policy responsibility around older people's mental health in general, so focusing on the functional side of things, which I'll go on to talk about a bit more. I think that was, hopefully you would agree, that was really useful to get a picture from James and Fiona of how they are doing this work in their local area. And I completely appreciate that this is obviously a webinar that's focused on psychiatry and the old age faculty, but I think one of the things that hopefully Fiona's and James's presentation, as well as my presentation, will bring out is that this isn't just about psychiatry at all, and I'll bring that out sort of more clearly as I get towards the top tips and some of the key recommendations that I'm going to talk to a bit later. But it's worth just bearing in mind that absolutely aware that a lot of what we're discussing and talking about isn't about clinical practice. So some of it may seem quite sort of managerial, some of it might seem like it's tied up in governance and planning. But I think we've had a lot of interesting conversations over the past few years, and there's a clear need for clinical expertise and clinical leadership to lend itself to some of the wider questions around planning. And I think that links back to Amanda's very important and fundamental point at the beginning around championing the needs of this age group. And that can't just rely on sort of managers or planners, who are obviously the ones who are going to be leading a lot of this work. But I think a lot of it's about leading really from the front and kind of agitating, and I would say throwing your weight around in a good way. And as I said, I'll talk about that a bit more towards the end. So just to touch upon context really. So the NHS long-term plan and the mental health implementation plan that we published on the back of it. So that the implementation plan was published in July last year. And it set out a fair bit more detail around the mental health priorities in the overall NHS long-term plan, and quite a bit more detail around the new funding that has been and will continue to be made available up to and including 2023-24. So in terms of the specific older adult content, what Claire Murdoch as the National Director for Mental Health talks about is obviously a little bit tongue-in-cheek. She talks about the silver thread. So particularly for all of our adult ambitions, making sure that there is due consideration given to older adults. We know that hasn't happened equitably in the past, and that's why we want to really use this opportunity to address that very explicitly. So the high level expectations on local systems, so this is mainly thinking about sustainability and transformation partnerships or integrated care systems. So I'm sure you'll have heard about these in your faculty discussions, but the kind of local health and care governance bodies going forward, not formal, not statutory at the moment, but very much the bodies around planning. So all of these will need to plan to achieve improvements in access and treatment for older adults in line with local demographics for all mental health services. So the idea is that access to dedicated older people's mental health support will be based on needs and not age, and thinking about removing upper age barriers to access. So we know that, again, there are these kind of continued trends across mental health care around exclusions and rigidity, and we really want to tackle some of that. So firstly, thinking about how older people's mental health staff, including old age psychiatry, works more closely with physical health and other older people's integrated multidisciplinary teams. So there are other big nationally driven initiatives through the NHS long-term plan, such as the Ageing Well programme. And so a lot of this is based on wrapping care around the individual and working on the primary care network footprint. So this is about the kind of neighbourhood approach where we're talking about 30 to 50,000 populations and building from there. And I think there are some really key messages around the need for different parts of the system. So NHS mental health services, physical health services, social care, obviously really thinking about the massive impact that COVID has had in care homes. So there are even more impetuses to get this done than before. So we're not just thinking about where older people's mental health expertise sits at the moment. We're thinking about where does it need to sit and how can it also expand. So one of the things that Fiona touched upon was the core competency framework on older people's mental health. We've asked HEE to publish an interim competency framework because we know that COVID is having a disproportionate impact on older adults given the physical health vulnerability. So that is now published. There is a link there. It's on the e-learning for health website that's associated with HEE. Now the next slide, please. So these were some of our expectations for the early implementer site. So we've provided a significant amount of funding, over £70 million of funding last year and this financial year, to 12 early implementer sites who are testing the new models. One of those sites is obviously Sheffield, and you just heard from these colleagues. So some of our expectations were some of the things I've already talked about. So working more closely with other teams, especially around things like frailty and support in care homes, really thinking about proportional increases based on need, and ensuring that older people receive sort of equitable improvements in care as compared to the working age population, and really thinking about personalised care and what does that actually mean for this cohort. Of course, there's been many changes in light of COVID to overall service provision, changes in our understanding of need. So we're going to be reviewing these ahead of 2021-22. So the really worth bearing in mind that there is new money for this. All systems will be implementing these new models starting in the next financial year, and we're planning to fire the starting gun on that formal planning process this autumn. So I think that's why this is a very timely moment to have this conversation with you. And just to pick up very briefly on something that's come up in the Q&A bit, just to be very clear, this is around older adults with functional mental health problems. So obviously these people may have coexisting dementia or cognitive issues, but our main focus is around functional mental health problems and specifically severe mental health problems, but absolutely recognising there needs to be improved care for people with coexisting needs. And that's why we do specifically pick up, for example, older adults with frailty, people of all ages over the age of 18 with substance use needs, so drug and alcohol conditions as well. Next slide, please. So I've just set out some key steps to consider in the community mental health transformation. So there are only a few months now until we fire as I said, we fire the starting gun with our SCP and ICS colleagues working across England on the formal planning process. And I think there's a really key important point around leadership. So Fiona's made the point from a kind of local perspective, but in terms of what we would like to encourage in NHSE&I is around you being the change that you want to see and the improvements you want to see in older people's mental health. They're not going to come magically from elsewhere. So we really need psychiatrists as part of this conversation to step up to the plate and to really be part of those conversations, to be proactively involving yourselves, inserting yourselves into those local discussions, making yourself known to your local leads in your STPs and ICSs, within your mental health providers, so letting your provider exec teams know that you are willing, ready and able to advocate for older people's mental health to benefit from this transformation and from the new investment coming down the track. Thinking about demand and capacity currently in older people's mental health services, thinking about the conversations around the dedicated services versus needing to spread and increase the competence and confidence of the whole workforce around older people's mental health, as well as bringing in specific expertise where people's professional backgrounds have allowed them to specialise in older people's mental health. I think another key point is around collaboration. So yes, psychiatry is an absolutely key part of this and a critical part of this, but it's not just the answer here. This requires whole system collaboration. It's about integrated care for the individual. So it's not about a single professional group or a single service area. And we really need to push continually the message around the person at the centre, the older person at the centre. There are really important opportunities around the developments that are separately funded and separately driven, but need to locally be coordinated around frailty pathways. So we're really thinking about how can this be operationalised through, for example, joint management and shared care approaches, potential things around transition protocols, although generally we really want to move away from this idea of handoffs, constant handoffs. But of course, we know there's limited expertise. So as well as building it, we want to understand how a more collaborative approach can be sort of formalised and work better in the interests of the patients. MDT working, really thinking about seamless care. So I think that kind of leads on to a general point around being creative in some of your considerations around how you build your older people's mental health workforce. So yes to clinical roles, but also non-clinical roles. Fiona and James talked about the BCSE contracting with third sector organisations, not necessarily just the usual suspects, but really thinking about very localised, sort of small and sort of micro community groups as well, and how they can be pulled in to be an important part of the model. Training, credentialing, shared care. So again, as generous system partners, there's a lot of potential here. I think finally, I'd just make a point around the equalities angle. So I think as a faculty, you've talked quite a lot about age as a kind of equality consideration. So that does need to be followed through in terms of looking at those age thresholds, thinking about the overall narrative. So inequalities is about a whole range of things and protected characteristics, including age. So continuing to push that within the narrative, and of course thinking about how the narrative can be strengthened, because COVID-19 has had a significant impact on this age group. So it was already a historically underserved group. This inequality has become even more stark, so using that to strengthen arguments. So I'll leave it there, and I think it's up to Josie now to pick up the Q&A, if that's okay.
Can you all hear me?
Yeah.
Good. Thanks so much for joining us this evening and for those great presentations. You've been very active on the Q&A, and I can see that some of the speakers have been addressing questions as they've been going along, which is really great. We had a couple of questions come in actually before the webinar, so I'm going to get to those first and then work through some of the main things that have come up, and I'll group some things together as they're along similar themes. So firstly, I think this is one for Krish. From Dr. Prasanna De Silva, who I think is local to your area, Krish. Are other mental health trusts actively trialling rapid triage? We are at CNTW, which is Cumbria, Northumberland, Tyne and Wear. Krish, over to you.
You're muted.
Thanks, Prasanna. Sorry, it's a good comment rather than a question. It's good to see initiative, and I think Jonathan is in the webinar, who is one of our faculty executive members. So if I'm able to get a summary of the initiative, because it's a good practice, we'll be more than happy to share it to wider faculty members so that they can look at the project. And it's anything sooner to triage and signpost patients to access our older people mental health services, definitely useful. So if you or Jonathan could send me the summary, I will be more than happy to share it to the faculty members. Thank you. Thanks, Josie.
Okay, thanks, Krish. And another question that came in before the webinar, I think I'll direct this one to Viral. So this is from Dr. Tony Rao. I've spent the past 15 years developing service for older people with mental disorders and coexisting alcohol use disorders. Will there be opportunity to share this expertise and lessons learned with the pilot sites?
Yeah, so thanks to Tony. I'm not sure if you're on the webinar or not, but we have met before and talked about disseminating some of the information and learning to those sites. So yes, that offer is very much still there. They are, I think, aware of some of this as we've presented beforehand. So yes, absolutely, send through the information and we can share it freely.
Lovely, thanks for that, Viral. And now I've just got a few questions grouped together, which I thought might be good for Fiona and James. I hope that's all right. And so firstly, from Rupert McShane in Oxford, could you give concrete examples of what I, as a psychiatrist, might be doing differently? Also, question about, are consultants dual trained? That's an anonymous one. And are the team generic workers? Another anonymous one. And also, could you comment on any outcome measures used, CROMs or PROMs, so that's clinician rated outcome measures or patient rated outcome measures, and that's from Jonathan Richardson again.
Okay, so let's see if I can I unmute?
I've unmuted.
Oh.
Ready.
We can hear you.
Oh, she is muted.
We could hear you before, guys.
Yeah.
Can you hear me now?
Yeah.
Yes.
Okay, so it's Fiona here. I'll respond to Rupert's question and the one about generic workers, and James, I think, will come back on the outcome measures. So in answer to what will you as a psychiatrist be doing differently? Well, from day one, possibly not an awful lot, actually, Rupert. We're testing, we have a very small amount of psychiatry in our programme, and what we're working out is exactly what the mental health nurses, the psychologists, the GPs, the pharmacists, the community connectors and the psychiatrists can and should be doing, what's unique and what's separate, and we're trying to work out what is secondary cares, what's primary cares, and what's that bit in the middle between primary and secondary care that we can actually increase the resource on offer through our partnership with the third sector. So I think at the moment what the psychiatrist's role is very much helping us to work out what the rest of the team can be doing, and working with the GPs in a consultant role to help to shape what stays in primary care and what comes into secondary care. So that's what's happening at the moment, and that's what we're doing with our psychiatry. We've got some expertise from an old age psychiatrist, some expertise from a psychiatrist who is used to working with student populations, and then the other psychiatry input is really somebody who works in our single point of access, who's keen to work more closely on how we support ensuring that people have access and support without necessarily coming into secondary mental health teams. So that's what we're testing. And then beyond the pilot sites, what will you be doing differently? Well, I guess it's going to be around what works from the pilot sites that can be rolled out more broadly for the rest of England. Are the staff generic workers? No. We have primary care mental health nurses who are, if you like, mental health nurses by background. So they are band 7s, and they are doing that kind of triage and signposting. We have a team of psychologists who work and psychotherapists who are working on the personality disorder pathway, improving access to psychological interventions. So they're not generic workers, but some of them are old age experts in functional mental illness. And then our community connectors, those are new roles, as is the pharmacy, liaison pharmacy role. Those are not generic because those people have got their expertise in relation to social prescribing or in pharmacy, but it's what's new is where it's being delivered and with kind of population health focus in mind. So I'll hand over to James, because we're doing quite a lot of different things on outcomes, both locally and nationally. So James can pick up the local piece.
Many thanks, Fiona. And to answer the question about the patient-related experience and outcome measures, we've worked in Sheffield, we're using the Office of National Statistics 4 scale on wellbeing as a nationally validated and accredited tool to show the day-to-day, week-to-week, month-to-month changes as a result of the system change. We're also using the Picker Institute survey on integrated care to capture our patient-related experience measures. To our knowledge, this is the only validated tool for actually experience measures. What we've done on the back of that as well is we've aligned our person-centred care statements for both patients and carers to that integrated care survey. Additionally to that, we're always going to have a basket of measures as well. So there's going to be essentially the what's important for me in terms of our wider partners, the wider system. So, for example, there will be additional measures for secondary care colleagues, which may be clinical measures, that may be non-clinical as well, such as the impact on referrals through to the single point of access or the number of inappropriate referrals, uptake or change in the number of crisis presentations. Similarly, there'll be different measures again that are important to colleagues in GP practices and primary care networks, which might actually be what was the length of time of contact between patients' appointments, or increased uptake in the number of individuals registered to that practice receiving physical health checks, and also the behaviour change activities associated with that. Additionally, we'll work with Viral and colleagues in both the national team and regional teams for NHS England's reporting as well, and we are in the process of appointing an ongoing evaluation and recruitment partner as well for the programme. But I hope that answers your questions.
Muted.
You're muted, Josie.
So sorry, I've been doing really well with Teams all week. Okay, so sorry, we're not going to be able to get to all the questions. There are a few more flooding in. I've got some specific ones that I really want to give to Viral. So a couple of questions about evaluation and research. So are you evaluating the impact of this sort of model on older people, knowing that older people often have a poorer outcome when services are combined? So that's specifically from Dr. James Warner. Dr. McShane has also asked about testing the evidence. So is there any formal research being done alongside these changes?
Yeah, so simple answer to the first one, yes. So I've been trying to type some answers into the Q&A. I'm not sure if everyone's been able to see them. Yes, so our evaluation approach is a kind of mix of local and some national. So we definitely want to see breakdowns of young adult age group, 18 to 25, working age adults and older adults. Appreciate that somewhat contradicts what I said about removing age barriers, but we do need to have a way to examine movement effects anyway. So yes, we will be looking at older adults from a positive perspective, and local sites will be doing their own separate work as well. On the formal research side, I mean, I suppose there's a general point around how long it takes to do any of this. So there are broad conversations happening around a kind of longer term piece of formal research. We in NHSE&I might sometimes get involved in that, but usually those conversations are driven elsewhere through the Department of Health and NIHR. So where we do determine there's a big gap or whatever, we will try and sort of push for that to be plugged, but these things take absolutely years, and there are a lot of things we already know. You know, I think the message from us is a lot of this will be around testing, iterating, a developmental approach, as opposed to waiting for 5+ years for a formal RCT or anything like that. I'm not kind of poo-pooing the need for formal research by any means, but I think we need to do both at the same time, instead of sort of continuously waiting for some sort of magical piece of research that's going to suddenly tell us everything we need to know.
Thanks, Viral. Just want to add my own thoughts into that, really. I appreciate what you're saying about the time aspect of longer term research, but in terms of building in evaluation to these new models from the get-go, we've had mention of PROMs, and Rupert McShane's mentioned a long-term conditions questionnaire as having good face validity to assess this sort of change. Has there been any thinking about the use of PROMs and PROMs more widely to kind of assess how this is going on a live basis rather than as part of a more formal research study?
Yeah, definitely. So we've had quite a few conversations with sites around where is the appetite around a lot of this. Definitely in terms of PROMs and PROMs more than PREMs. I think one of the difficulties is that PREMs, as far as we are aware, tend to be less well developed, because people have kind of relied historically upon FFT, friends and family tests, which quite frankly, I think has now been acknowledged, but has never been great and has always been very limited in what it's told people, hence it's now no longer a national metric. So I think more work needs to be done around the PREMS, definitely. I think at this stage we want to make sure that we also are asking the right questions around the qualitative side, so we're not just relying on a single measure, especially if there's not kind of consensus around what might work. So yeah, I think a lot of conversations around use of things like dialogue plus and requal. Those are some of the things that have come up in conversations. We're not yet falling on one side of the fence or another in terms of absolutely mandating. We'll definitely keep an eye on what's coming out, and especially how widespread use of these routine outcome measures are, because that's generally a big issue as well. If these aren't kind of flowing through international data sets and national reporting, that's its own kind of related issue in terms of having an overall transparency around what services are delivering beyond just activity.
Thanks, Farrell. That's great. A further question for you, anonymous question. How does the proposed programme help with the integration across the system, particularly with social services in areas where the services are not integrated?
Yeah, so I'm guessing this is a question around formal Section 75 agreements. We've had done a lot of thinking around this over the past few years, because there has been a kind of long-term move in a lot of cases, not every case, away from Section 75 agreements, probably on account of the pressures on local authority budgets and the effect that austerity has had on local government services in general. But the message from us is about that there isn't just one model of integrated working in town. So even if people are pulling out Section 75 agreements, some of which, some local authorities have done that a while ago, some are still doing that now and serving notice now, that isn't the only model of partnership working between the NHS and local authorities. So I think generally I would say local authorities are an absolutely key partner. We've asked them to be a key organisation signing off on the existing early implementers plans, and we'll maintain that expectation going forward into 21-22. But we would kind of encourage just the principle of partnership working. There are other models that are available and that do work to try and overcome some of those kind of barriers based on anxieties around formal arrangements. But we do agree that a bit more work needs to be done to articulate what those might look like and being sensitive to the particular pressures in local government.
Thanks, Farrell. And another question for you from Alex Bailey. So it's unclear if funding and implementation of any of this is driven through the mental health chapter of the long-term plan or Ageing Well. Do we get a bite of the cherry from both, one or none?
So pretty much everything I've spoken about today is based on the mental health side, so the community mental health transformation funding. But the idea really is both, because that joint planning does need to take place. So ultimately, the vast majority of what I've talked about is relating to the funding coming through from the mental health programme. But as I said, that a lot of that join up work does need to happen at a local level. We will do our best on the messaging, so across the national teams, across our regional teams, but at a local level, that sort of join up does need to be encouraged and pushed, particularly through the clinical lens.
Thank you. And last one for you. I feel like I'm giving you a bit of a grilling. Thanks for asking all these questions. So this one is again anonymous. The reason barriers are put up by psychiatric services is that money doesn't follow patients, unlike in general medicine, where hospitals get more money when they see more patients. Unless this is addressed, it's hard to see how barriers will fall. Just wondering if you have any thoughts on that point.
Yeah, I mean, I would challenge that. To be honest, I think barriers are put up by all sorts of services. It's just mental health services happen to be, I suppose, a bit more notorious for it, perhaps unfairly. And I do agree, I think it would be ridiculous to even attempt to deny there hasn't been an issue of historic underfunding. So things like the long-term plan are steps to try and address that, but obviously it's still part of a longer-term process. I mean, having said that, in my experience, a lot of other services do put up barriers, and it's not relating to the money not following patients, or especially even in things like, if you think about the changes in A&E departments and the constant conversations around changing payment models, changing incentive models, etc., etc. There's not really been a clear solution there. I do agree, having said that, that sort of payment reform and looking at different currency options in mental health, we do know that work's been slower than it possibly should have been. I think that's widely acknowledged now. So part of what we want to understand through this work is are there other things we can do, like exploring things like year of care payments, especially if we're talking about people with sort of severe and enduring mental health problems who will continue to need sort of packages of care, or at least forms of care that are long running and long term. But I think it's still relatively early days in terms of our thinking around that, and we'll probably start to really look into that properly within the next year or so.
Thank you. And just mindful that there's quite a lot of questions that we haven't got to, which I think you're best placed to answer, Viral. Without wishing to bombard you, I'm wondering if there's any way that we could get questions to you outside of this webinar.
Yeah, very, very happy. So if Kitty and colleagues could maybe collate, then I'm happy to answer whatever I haven't been able to answer. Just to emphasise as well that the money I've talked about, please do go and read the mental health implementation plan. So that sets out that, as well as 5 years of additional funding in CCG baseline, so that's the funding that all CCGs have at the beginning of each financial year. So the money for community mental health goes up throughout that. I mentioned the transformation funding that we're making available to the early implementer sites, so 1920 last financial year and this financial year. But on top of that, there will be 3 years of transformation funding. So the planning process for 21-22 that I've referred to is effectively the first year of a 3-year process of transformation funding that again goes up. So it's worth bearing in mind that this isn't just a kind of one-off exercise. This is about the kind of first steps in what should be a lasting, wide-ranging and kind of systemic change. But yes, happy to answer those questions if RC Psych colleagues are able to pull them together.
Thank you, that's great. And I've posted Kitty's email address in the live event Q&A. So if there are further questions, then we will pass them on that way. We're about to run out of time. I just wanted to go back to Amanda and Krish briefly, if that's all right. I'll squeeze this question in. There's a really good question, I thought, which is, can we have a platform where all the joined work in different localities might be shared? And also for Amanda, is there any update in credentialing in mental health for older people?
Do you want me to go first?
I don't mind.
Yeah.
Yeah.
Yeah, that's, I think it's from Rashi Negi, I think. So I think it's important thing, Rashi, that we share, like I answered the question about Prasanna De Silva. I do think that from in the faculty website, we do need to look at places where we can share and spread information, and I will try my best to collate some of that and then start populating it in the faculty website. With regard to credentialing, Amanda, do you want to?
Yeah. So when it comes to resources, just to be clear, at the moment, because the college is very concerned about what goes on the college, even our faculty website, we have to, if anything's sent in, any good practice, we look through it, we then send it up to the college, and then the college go through and see whether it's okay. So it's not a system where anything goes on it. Just to be clear, we do have to follow process, and it does take a bit of time. With regard to the credentialing, no, there isn't at this moment. There is the kind of push in credentialing, I think, has been more around neuropsychiatry. I'm not quite sure why, but I think that's where there is some credentialing. But at this moment, we've talked to the Dean, we've talked to Alistair, and there's no actual plan at this moment that I'm aware of. Now, we have got, there's a revamping of the DGM, where we've got somebody from the faculty being involved in that, and I don't know how that's going to look and what would happen there, but there's no plan at the moment for credentialing, but it's something that I know Chris is got his eyes on. So
Amanda, shall I just come in there?
Yeah.
So HEE have actually started the first bit of work around credentialing in older people's mental health. So it's still kind of relatively early stages. The first phase of that work is going to be seeking to speak to older adults mental health experts within the early implementer sites, but there will of course be sort of wider discussions that need to be had, especially given that they're still in the kind of scoping phase. But that piece of work has formally started. I can't speak on behalf of HE colleagues around timescales and deliverables and outputs, etc., but it's definitely worth the faculty being aware of that. And I'm sure in due course, when it's figured out what the next steps are, there will be wider involvement and kind of stakeholder views will be sought.
Can I just plead that we are, please that we are involved in that? Yeah, I'm really pleased that we are involved in that, because, you know, we don't come in late to this, and if that is happening, and we don't know about it, that'll be. So thanks for that update, but we definitely want to be involved. Okay, I'm going to hand over to Chris to pull things together. I think we'll come to the end.
Okay, so I think we've got about 125 people at the webinar, which is very good. And with the amount of questions, again, thanks Viral for patiently answering and also going to agree to answer more questions. And it is as Amanda mentioned, Viral has already mentioned, it is about the recurrent funding. So please go back to your services, speak to your service managers, your CCGs and PCNs to see how this could be you can get the applications started, and that's the key message. That's why we wanted to bring this topic into this webinar, and look forward to further webinars and faculty update very soon, and hope you all, it's a nice sunny day, so we don't want to take any more of your time. Thank you to all the speakers. Thanks to Amanda, Viral, Fiona and James, and thanks Josie to nicely summarizing the questions, and thank you to our RC Psych colleagues, Kitty, Devan, and two other people, I forgot the name. So thank you so much for helping us, and we'll see you soon in another event, and hope you all have a good evening. Thank you.